Hello, my name is Christy Bucci, and Amy Daniels will be on also. We are going to be delivering education on an EMS standardized handoff tool. So just to give you a little history of the project and how it came about, last year for an EMS conference, our EMS outreach requested this education to be presented on a standardized handoff tool. It's been identified that there is no standardization in EMS to RN handoff, which can lead to potential harm for patients from communication breakdown. As we all know, it has also caused strained relationships between the disciplines. So once we began the research, identifying a standardized tool, looking into communication and the effects of it, we identified there was a need for it. The content was developed from that research that you're going to be presented. The EMS outreach have an educational session each month. We did present the education and the standardized tool in this EMS outreach educational session. We got great feedback from it. So from that information, we determined that we were going to do a pilot study with all of Campbell County Fire EMS and the Fort Thomas Emergency Department. We presented this information to the Campbell County, Pendleton County Fire Chiefs meeting, where we did get positive feedback from the fire chiefs that a tool would be very beneficial to our patients. Along with that, Amy and I also had submitted this presentation to the Emergency Nurses Association, or the ENA conference. It is in New Orleans this year in September, that we will be presenting this project on a national level also. So this is our project timeline. We are on kind of a tight squeeze because of that ENA conference that we are heading to, but you guys should have already received the survey for pre-data collection. Just some behavioral questions. What do you use? Have you used it? Do you feel it would be beneficial? Those types of questions should hopefully not take you any longer than 5 minutes to complete. We currently are undergoing education for both EMS and the nurses. The nurses at Fort Thomas Emergency Department are also receiving the same education with expectations on their end, so they know what to do when you all are coming in. The go live date for this is June 9th, where the IMIST will be implemented into the standardized tool to be used for handoff. In July, we will send out another survey after the IMIST has been used for approximately 1 month to get some post-survey feedback. How did it go? What did you think? Do you feel like the tool is beneficial? Hopefully around the end of the month, after we have compiled all that data, we will present that post-data information to you guys so you know how the study went. On the next slide I'm about to start for you all, you're going to watch a video on a bad handoff. It is very much dramatized, but I can tell you that some of the things that go on the video, I do know happens. Amy knows it happens. I'm sure you all know it happens. So we are trying to do a better handoff for our patients.
So what are you guys doing this weekend?
I don't know. I think we're going to go out downtown and talk to people and I'm going to do that.
That sounds fun. It's nice outside. I just
No.
can't wait to get out of here.
Excuse me.
I'm tired of being here
Me
too.
too.
Excuse me.
Can you hold on a second? Yeah, I'm tired of being here too.
I know. I think it's because of rain, so if it holds off. but-
Oh, hey, like sick patient here.
Hey,
Sick patient.
okay, take them over here.
I'm tired of being here.
Yes, it's non-stop.
Yeah. Just don't get it. I was thinking about it. Go to the doctor and do something fun.
Man, you should have seen the hole I pulled this one out of. Stuff was everywhere. Dog was barking. Annoying.
Okay, what are they here for?
Well, we got a call for chest pain, shortness of breath. And she was tripoding when we got there. Dude, the place reeked of smoke. I don't think I'll be able to get that out of my mustache.
Alright, did you guys do anything for them at all?
I mean, I tried an IV, but she said they usually use an ultrasound, so then I decided not to. But, you know.
Okay, alright. Let's just move them over to the bed.
Alright, ready? 1,
Yeah.
2.
Hey, can you just get over here? Just sit on the bed.
Here, can you go ahead and put this stuff on since you didn't do anything?
Can you bring an EKG machine in here? We'll probably
Alright,
do that
so
later.
she did say she was allergic to sulfa. You wanted to know that.
Okay, yep, we're good.
So,
Can you
but
go ahead and get out of my way so I can get this done?
sure. My pleasure.
Don't come back.
So from the research that I did, I want to just give you some background on communication and a standardized tool, why it is important to incorporate into practice. Incomplete handoff is the main cause of adverse events. According to the American College of Emergency Physician, this is the most dangerous point in the patient's journey is during the handoff. 70% of serious medical errors are associated with miscommunication. Some of the common errors that were found through the research were medication errors, treatment not being reported, and potential misdiagnosis due to misinformation. Patient-specific information is also missed, such as allergies, pertinent medical history, and their demographics. One of the other aspects of communication is that definitive transfer of responsibility. When does this occur? When the medics are coming in with a patient, when does the hospital staff assume responsibility of that patient? Is it at the doors? Is it at the bedside? Is it after that handoff is complete? So those were some of the common things with communication research. So what are some potential barriers that you guys are seeing that do affect handoff? That lack of closed loop communication. There's so much going on in the room. There's a lot of talking. There's a lot of chaos. And that leads you all to having to give unnecessary repetition of information. The nurses aren't paying attention, or maybe they're talking, and then you guys have to continuously repeat yourselves. Or if the nurse can't remember what you said, she's asking you the same questions. Sometimes excessive details are given. You know, we want to tell a story, but that information isn't necessary or pertinent to the patient's care. Noise levels are constant. You guys know it as well as we do. The radios are going, people are banging into the stretchers, they're moving the patient while you're trying to give report, not paying attention, equipment's being thrown around the room. Those interruptions are reported to occur 20% of the time, and I'm willing to bet when we see our surveys that it's going to be higher than that. This can cause delay in care, and sometimes the patients are interjecting because of the rudeness between the staff. You know, they're not feeling like they're getting the care they deserve. This also causes tension in between medics and the medical staff at the hospital, makes you guys not trust us, makes, you know, the nurses not trust the paramedics, and then there becomes a huge lack of respect for one another.
Benefits of utilizing a standardized reporting tool are that it provides an effective tool for communication. It keeps things organized, focused, and brief. And that way it will get you guys out on the streets or back to the station sooner. It also helps with teamwork. So by being like on the hospital side, us being active listeners, it shows that we're being respectful, and the patients will see that. They do feel that when we are in the room together. It provides a definitive transfer in care. So when you are done giving a report, then you're done. You can go ahead and head on out, and you know that the nurse has the patient and you are good to go. It also provides a little bit of time at the end for feedback if there are any clarifying questions, but really by utilizing a standardized reporting tool, it should be all encompassing. All the information should be packed into that tool. So like me as a nurse, if I know you're going to be using this tool, you're going to start at A, and I know you're going to end at Z, and you're going to get to E in the middle where I already know I'm going to ask about it, but I don't have to. I don't have to interrupt you because I know you're going to hit that point because I know what to expect when you come in the door. So this is the reporting tool that has been agreed upon. It's called IMIST. You may or may not have heard of it. So I'm going to go over it here with you all. The I stands for identify, so that's that demographic information, the name, date of birth, male, female. That is a key piece of information for the hospital so that we can get the patient in the system and start ordering orders after you've given report, of course. M is mechanism of injury or medical complaint. So what was the reason for the call? You know, shortness of breath, chest pain, I stubbed my toe kind of thing. I is injuries or information related to the injury or complaint. So they called for chest pain, and some pertinent medical history would be, they had a recent stent, allergies, or allergic to amoxicillin, and then any meds that are pertinent to the complaint. So we don't need grandma's whole med list and supplements. We just, maybe if she was there for chest pain, knowing she's anticoagulated or on metoprolol, a beta blocker or something. S, signs and symptoms. So that's your vital signs, your physical exam, and your assessment. T is treatment and trends. So what did you do for this patient, and did it work or did it not, kind of thing. So expectations for this pilot is that every time that you go to Fort Thomas, that you utilized IMIST for giving report. Only report the information required by the standardized tool that should encompass everything needed. You need to make sure that you identify who you're giving report to. So I know sometimes you walk in and the charge nurse might expect a full report. That's not necessary. Like we did say, our charge nurses and, well, all nurses in Fort Thomas right now are getting this education. So they know that, the charge nurse, they just need a quick, or what are they here for? Short of breath, chest pain, whatever. And then when you get to the room, you'll be able to give a full report to the primary nurse. Please be patient with us. Obviously, with any new implementation, there are going to be some hiccups along the way. But do notify us if you see consistent trends of, a lack of receptiveness to your all giving report. The ED manager, Laura Simpson, is totally on board with this. So please make sure that you let us know if you have any feedback. As for environmental, so if you can, if it's safe to do so, please turn down the radio so they're not screaming over top of all the other chaos going on in the room. And then try to initiate movement of the patient prior to starting report. That way we're not trying to move the patient and, inevitably the wires get stuck on something and then we get distracted in the middle of report, and you know how it goes. And then if possible, encourage the patient to be part of handoff. Like, for example, so if we don't remember the onset or the duration of the chest pain or whatever it may be, just, you can say, oh, and how long ago did you say that started, sort of thing. It helps the patient feel validated and that they're being heard. And then try to shut the doors as well. It helps with the volume levels of the room, but also we typically end up getting our patients in the gown, so it helps provide for privacy as well. So this next slide that I'm going to show you is another video, and it is an example of how well a report can go when implementing a standardized reporting tool.
What are you doing this weekend?
I don't know, I think we're gonna go out downtown, there's that concert going on.
Hey guys.
Hey,
Hello.
hi guys.
Hey, good. Got a meeting for you.
Okay. Hi, my name's Drake, thanks for choosing General Hospital. What's going on today?
I'm having some chest pain. I'm feeling pretty short of breath.
Okay, let's get you over here to the bed, okay? You mind taking her over there?
Yeah, absolutely. Alright.
You wanna try and move her over?
I think she can scoot over. She did pretty good at the house.
Do you feel like you can move over here? Okay, I'll take your purse here. What do you got for a report?
Let me turn my radio down to avoid distractions.
Thank you.
All right, so I have 97-year-old female Janice Huff, complaint of chest pain, shortness of breath. Had a recent MI with stent placement. So she also is a 2-pack per day smoker.
Okay.
And she's on 2 liters of oxygen at home. So blood pressure is 158/76. O2 is 87% on 2 liters. Heart rate's 110, respirators 32. She's afebrile at 98.6. Blood sugar is 98. This is her 12 lead.
Thank you.
So we did get a left 20 in the left AC. So I went ahead and gave her 1 nitro for the chest pain she's complaining of. She said it's about an 8 out of 10. No relief there. Did also give her a breathing treatment en route. She's diminished bilaterally and has a little bit of crackles going on. So gave her breathing treatment. So we're still waiting to see the effects of that. At home, she was tripoding. So we did transport her in an upright position for comfort.
Okay.
And we did use lights and sirens given that she just had an MI with stent placement.
All right, sounds good. Thank you, I appreciate it.
Yeah.
We'll take it from here.
Yep. Have a good day.
Thanks, you too. Be safe.
Will do.
How are you feeling today?
My chest is really hurting.
Okay, we'll get you taken care of, all right?
Thank you.
See, that went a lot better than the previous. So the just for that example, that scenario, I went ahead and put it into the IMIST. So it would go a little bit at something like this. So Janice Huff, 97-year-old female with a date of birth, came in for shortness of breath, chest pain, 8 out of 10. She had a recent MI with stent placement. She has a history of COPD. She's a 2-pack per day smoker on 2 liters of oxygen at home. She is diminished bilaterally with crackles, and she was tripoding upon arrival. Her blood pressure is 158/76, O2 87% on that 2 liters. Heart rate's 110, respiratory are 32, temperature 98.6, sugar is 98, and her pain is an 8 out of 10. We did get a 20 in the left AC, a 12 lead that shows AFib. She did get a breathing treatment en route, and literally right as we walked in the door, so still waiting to see how that went for her. And we did give her a nitro en route as well, and she reported no relief. So as you can see, that report was super concise. It gives you all the information that you need to take care of the patient and really helps to really just narrow it all down. This concludes our presentation. Provided our contact information listed to the left of the screen. Christy, myself, Laura Simpson, the manager of Fort Thomas, and our EMS outreach team, Chris, Josh, and Tony. Please feel free to reach out to us if you have any comments, questions, concerns about this project. We have also included the QR code for the survey. If you have not yet completed this, please do so. It helps us to compile the data, shows need for this intervention, and we need this also for the conference, so we would just really appreciate it. It's very short, sweet, I promise. But thank you all for taking time to listen to this today. We look forward to working with you, and we appreciate everything you all do.